Good morning, everyone. How are you? I hope you've had a lovely evening. Heard a lot of people had very late nights. So some of you might be feeling a little bit dusty this morning. So I hope you've got your coffee, your waters, and you're all prepared for another big day. It's hard to believe that this is the final day of this incredible symposium, and I think it's been such a pleasure to witness everyone come together in this way, to learn, to listen, to grow, to thrive, much like really the industry has been doing over these past 5 years. I'd like to thank, even though she's not here, the amazing Lucy Haslam, whose tireless advocacy has proved an extraordinary catalyst for change today. We look forward to seeing where the last 3 days goes. We look forward to seeing it actually move ahead and materialise as new endeavours are born and new thought is inspired. And I think that's a good place to introduce today's first speaker. We're so lucky to have Dr. Peter Grinspoon joining us live this morning. Dr. Peter Grinspoon is a primary care physician at Massachusetts General Hospital, an instructor at Harvard Medical School, and a certified health and wellness coach. He is a board member of the advocacy group Doctors for Cannabis Regulation. He is a contributing editor to Harvard Health Publications. His 2016 book, Free Refills, A Doctor Confronts His Addiction, published by Hachette Books Group, was the first memoir by a physician to confess to and describe recovery from an opiate addiction. Dr. Peter Grinspoon joins us live now from Boston. His presentation is titled Cannabis and Opioid Sparing, A Personal Journey. Please welcome Dr. Peter Grinspoon.
So I thought it would be a good idea to be at my daughter's graduation, but I would love to be down there otherwise. And I also want to apologize that I have a lot of slides. So I'm happy to make my slides available to anybody after. And there are a couple of them I might just skip over. But how did I get involved in this issue? First of all, I'm a general doctor, a primary care doctor at Harvard in Boston. And I also work for a great advocacy group called Doctors for Cannabis Regulation that is working on both legalization. We still, in the United States, in one part, you could make $1 million selling cannabis. And in another part of the country, you can go to prison for 10 years for selling the same cannabis. So we're trying to get it legalized, but also trying to educate doctors. Because if you probably noticed, doctors don't know that much about cannabis yet. So we're working on it. And how did I get involved in this issue? I've been involved in this issue literally my entire life. My parents in the early 1970s used medical cannabis on my brother Danny because he was fighting an unsuccessful battle with leukemia. And I saw, I was like 8, 9, I saw at a very early age that medical cannabis did help people, did really alleviate, at least for that particular indication, the symptoms of chemotherapy-induced nausea and vomiting. So as I went through my medical career, I was like sort of pro-medical cannabis, so like help my brother. That's a pretty impactful, informative memory. Also, my dad, who I'll talk about in a minute, Lester Grinspoon, was a huge advocate for legalizing cannabis. He wrote a book in 1971 when 13% of Americans supported legalization. And he called for the legalization and said we were doing more harm to people by criminalizing it than by, regulating it. So growing up, I had all kinds of advocates and some detractors debating medical cannabis and cannabis in general throughout my entire childhood. In our living room would be like a cloud of marijuana smoke and like the brightest people you could possibly imagine discussing things, these conversations fueled by cannabis. They were really inspiring as I was growing up, and then I'd go to school and the policeman would lumber in and be like, marijuana causes amotivational syndrome. And what I saw at home and what I saw at school were like completely different. And what I saw at home was actually a lot more compelling because I was dealing with these like really bright people that were sort of demonstrating and advocating for cannabis. I'm a medical cannabis provider. I've treated people for like decades. It's a lot easier now that it's legal, at least in the state where I am. And finally, I'm personally in recovery from opiate addiction about 14 years, as they mentioned in the introduction. So I feel like I know a lot about opiate addiction and cannabis and how cannabis can supplant opiates, because I've been through the opiate issue from every possible direction. I treat patients with buprenorphine, I've treated physicians, and I've recovered, which is not that easy to do. Anyways, here's a picture of my dad taking the first puff off the first joint that was legalized in my home state of Massachusetts, something that he had been working on literally for 50 years. 50 years later, he finally, unfortunately, he passed away a couple years ago, but finally he got to see it legalized, not federally, not across the United States like Canada has done or Uruguay, but at least in our state and in increasing number of states now. 18 out of the 52 now have complete legalization of cannabis. And this is Steve Mendili. He's an activist that I work closely with. He's a veteran. He's like a poster child for someone who was injured during, our war in Iraq, our war in Afghanistan, and has a lot of chronic pain. And our Veterans Administration just literally throws benzodiazepines and opiates at our veterans. And he just said, no, I've had enough. I want to use medical cannabis instead. And Steve's doing really well with the medical cannabis. So he's like living proof that, as am I sort of, but living proof that you could supplant cannabis for opiates for chronic pain and live a much better quality of life. I guess there's a strain called Dr. Grinspoon, originated in Barney's in Amsterdam, but it's about my dad, not about me, unfortunately. And it says, as if channeling the brilliance of Dr. Grinspoon himself, this sativa is a top choice for creative, introspective thinkers. Anyways, just a quick reminder that until it was criminalized, at least in the United States and many other countries, cannabis was a reputable mainstream medication. This is just from Park Davis Company. They're owned by Pfizer. And now we have the same tinctures. They're coming back into vogue. We just had an 80-year period where we made it illegal. And in terms of making it illegal, I just did a very deep dive on this. There's never health and wellness. Health concerns were never at all a component of making cannabis illegal in the United States. And then we sort of tend to export our drug policy across the world. The biggest advocates for keeping cannabis legal in 1937 at the congressional hearings was the American Medical Association. So the doctors were really in favor of cannabis back then. And then it became illegal in 1937, but then they really started cracking down in the 1970s. And this is just, I'll spare you the whole quote, but it just it's Richard Nixon's domestic policy advisor saying that we knew the cannabis was fine. Did we know we were lying about the drugs? Of course we did. And just talking about how they used it to target sort of the blacks and the anti-war left instead of any public health concerns, which is, in public, they were like, smoke a joint, your legs fall off. But this is the calculation. They finally admitted it, that it was really sort of a contrived issue that they were doing for political purposes. This just briefly it's just interesting. A really smart reporter for the Boston Globe got one of Richard Nixon's daily briefing papers, and it just mentions my dad's book, Marijuana Reconsidered, and said to his colleague Haldeman, H, I'm sure I remember, this clown is far to the left. So my dad was very proud that the chief architect of the war on drugs specifically called him out as being a clown. That was like a compliment. But one of the main problems, I know this picture looks like that he's trying not to get COVID from the marijuana plant, but one of the main problems is that the research has been focused almost entirely on harm and not on benefit. This says that in 2018, research on the potential harms of cannabis received more than 20 times more funding than research on cannabis therapeutics. But that's in 2018. I mean, in the 1970s, 80s, 90s, it was impossible to get anything through in terms of looking for benefit. Don Abrams is a hero to the cannabis legalization movement. He had to pretend he was investigating the effects of HIV medication, of cannabis on an HIV medication, just to sneak in a study about how it actually helps people with HIV, AIDS, with wasting, and with pain control. So the data is really skewed. And I'm going to talk a little bit about data in a minute. There are harms, cannabis. Some people on the pro-cannabis side think it's not addictive. It can be addictive. I treat people for cannabis addiction, but it's not the 30% of adult users that our government claims it is. It's, a much lower number. And, again, I just recently did a very deep dive on all of this stuff because I just wrote a book that's coming out in early 2023 about this. And the data is really not as clear on any of this stuff as one would want it to be. Even something that I thought was sort of established, like, does it hurt the teen brain? The data is really scattered on this. Some brain scans are scary, some are normal, some cognitive studies they improve, others they get worse. So we still don't recommend it to teens because we're not sure. And as far as I'm concerned, we need to be, as a primary care doctor, a general doctor, very careful with pregnant women and breastfeeding women, just because we haven't proven that it's safe yet. But, there are certainly cases when a medical cannabis patient who's pregnant will need it if they have hyperemesis gravidarum or something like that. So I just think what it really comes down to, from the point of view of a cannabis clinician, is cannabis less harmful than whatever else you'd be using? And we're going to talk about pain, but you also think about sleeping pills. Ambien or zolpidem is like a lethal weapon. People go driving and don't realize they're driving. The benzodiazepines and the antihistamines can affect your memory. So my question is not, is cannabis safe or not safe, but is cannabis safer than whatever else I would be using in any particular indication? Also, drug interactions are, I'm sure this has been covered extensively in this conference, but drug interactions are pretty important. And they're really important too, because there's such poor communication between doctors and patients about medical cannabis. It's largely the doctor's fault. They have a very snooty and dismissive attitude. You don't take medical cannabis, do you? And the patient's like, no, of course not, doctor. And people are afraid to tell their medical providers that they use medical cannabis. And as a consequence, the doctors don't know. And there are drug interactions. And there are things like, if people use a heavy amount of cannabis, they need higher levels of anesthesia. There's nothing wrong with that, but it's just bad if the anesthesiologist doesn't know that you're using cannabis. So my main thing is I'm really interested in facilitating communication between doctors and patients on cannabis. The doctors also don't know very much about cannabis, which I'm going to talk about later, because it's just isn't taught in our medical schools, at least in the United States. The endocannabinoid system is taught in like 13% of medical schools. So people go to their doctor and try to get information, and it's like squeezing water from a stone. The doctor doesn't know anything about cannabis. So then the patients go to a store and they talk to what we call a bud tender, the person selling the cannabis at the store. And the doctors are like, oh, you shouldn't be getting medical advice from a bud tender. And the patients are like, but I tried to get advice from you and you didn't know anything about it. So where am I supposed to get advice from? So we do have a very difficult problem of like where patients can get credible, objective information about cannabis. Now, we have fewer arrests in the United States, but we still have 300,000 arrests in 2021 just for possession of cannabis. We have more people in prison than any other country, not all for cannabis. A lot of them, though, are for like ridiculous drug possession charges. This war on drugs has literally ripped the fabric of our society to shreds. But the rates of arrests are going down. But the other thing is blacks are arrested about 3.6 times as often as whites are. And we all use cannabis at the same rate. So there's a really important racial justice component to legalizing cannabis, as I'm sure all of you are aware. Now to get to what I'm supposed to be talking about, cannabis, chronic pain, and the opiate crisis. Doctors are not convinced about cannabis and pain. The International Association for the Study of Pain came out very recently and said, due to the lack of high quality clinical evidence, the IASP does not currently endorse the general use of cannabis and cannabinoids for pain relief. Then I think they got beaten senseless by the reality of the fact that there are millions of people that are using cannabis for pain relatively harmlessly and successfully. So they had to backtrack a little bit because they were getting clubbed senseless. And they said, we do not wish to dismiss the lived experiences of people with pain who have found benefit from their use. This is not a door closing on the topic, but rather a robust call for more rigorous and robust research. Much better attitude. But the question is, what counts as evidence? Aside from the fact that we've been looking just for harm and not for benefit. So, I mean, you just think about it. You're a scientist. You ask the question, is this harmful, yes or no? Or you ask the question, this is harmful, let us show that this is the case. That's not science, and that has tainted much of our literature. Until recently, it's getting a little bit better, but I would say until the last couple of years, like a huge percentage of the research in the US has been tainted by this bias against cannabis. And part of me thinks we need to throw it all out and start again, because these people weren't objective. They were anti-cannabis doing the science, and the scientists and the doctors were sort of, I guess the word is useful idiots in the war on drugs, the US government's war on drugs. If you wanted to make it as a researcher, you'd study harms of cannabis. If you were studying benefits of cannabis, no one would fund you. So, the other thing is, doctors say if there isn't a randomized controlled trial, it isn't really true. But more recently, we've been relying on real world evidence, which is, I'm sure this has been discussed as well, is health data, not from a randomized controlled trial, but from registries, observational studies, ecological studies, insurance data, patient recorded outcomes. These are really powerful. Real world evidence is basically evidence from people's actual experiences that are not randomized controlled trials. Cannabis is not great for randomized controlled trials in the sense that it's psychoactive. Most people know if they've been given cannabis versus placebo. That's why they use it recreationally, because it makes you feel differently. So obviously, if you give someone 10 milligrams of cannabis or a placebo pill, or they try to hide it with Benadryl or lorazepam, people know the difference. So it is pretty hard to do randomized controlled trials on cannabis. Furthermore, cannabis has about 500 different molecules in it, and randomized controlled trials tend to look at one thing at a time. I do want to point out that virtually all of the data saying for harms of cannabis is real world evidence. So what the medical establishment, at least in the United States, and I want to point out that most doctors are actually in favor of medical cannabis, but the medical societies, whether they're what I call old fart syndrome, or whether they're just completely bought and sold by the pharmaceutical industry or rehab or whatever, they are very slow to come along, and they've been pretty anti-cannabis. Most of our medical society, like the American Medical Association, the American Psychiatric Association, but all of the evidence they use to say that cannabis is harmful is real world evidence. So I don't understand how they could say that it's good enough to say that cannabis is harmful, but it isn't good enough to say that it's helpful. It just seems like this ridiculous double standard that everybody's letting them get away with. This is just an example. Stacy Gruber is one of my favorite researchers. She's at Harvard along with me. She's at a slightly different hospital, the one where my wife works. And she does a lot of great research. And this is just a study where they gave people cannabis. They gave other people not cannabis, and the pain got better at 3 months, at 6 months. The quality of life got better. I just don't understand how this isn't evidence in the eyes of a doctor or a researcher or a regulator. It's really well done. So we have this incredible opiate epidemic in the United States. I mean, it is a disaster. We literally have had 108,000 overdose deaths in the last year. Now, we've lost 1 million people to COVID in the last 2 years. So call it 500,000 a year. We're losing a fifth as many people from opiate overdoses as we are to COVID. I mean, it's absolutely crazy. We lost 49,000 people in the entire Vietnam War that people protested for 10 years. And within the last 12 months, we've lost 108,000 people to opiate overdoses. So we overprescribed opiates, which is part of the problem. But part of the problem is that once people are on opiates, it's very hard to transition them off, which I'll discuss. But I do want to mention that cannabis and opiates are about equally effective for chronic pain. For acute pain, you probably need you break your arm, you need an opiate. I mean, cannabis just isn't that strong. Cannabis is good for mild to moderate pain. If you have very severe pain, like a failed back syndrome or like metastatic cancer to your bones, then you're going to need an opiate. But for the chronic pain that like the average person, I should say, everybody's getting more rotund and more arthritic and their knees and their back hurts. I mean, there's no reason to put anybody on opiates for that. It's a worse quality of life and it's more dangerous. Cannabis is a great option. One point I make is that in all of these, again, part of this is the medical establishment being very slow to come around. But in all of these algorithms where they're begrudgingly starting to include cannabis in the algorithm, it's always like, if these 32 other medications haven't worked, then you might try medical cannabis. But I'd like to compare it with like non-steroidals, your ibuprofen, your naproxen, your Aleve, your diclofenac. I have so many patients in their 50s, 60s, and 70s whose kidneys are dying. And, now assuming these medications haven't given them a bleeding ulcer or a heart attack, if they've made it through all that, their kidneys are dying from taking so many non-steroidals for chronic pain. And we can prevent virtually all of this by using cannabis instead of the non-steroidals. So it's not just the opiates. It used to be, 20 years ago, that when someone wanted medical cannabis, or when my brother Danny, in 1973 needed medical cannabis, the only thing available was what the drug dealer had to offer. But now we have legalization, we have dispensaries, you can get an inhaler, suppository, a skin patch, a tincture, an edible, you can vaporize it in a safe way, you could use a topical, and there's so many different chemovars and so many different ratios of CBD, and with the new cannabinoids coming online, CBG and so forth, there's so much control now. And I just think the cannabis needs to be much higher up on the decision tree, because it is crazy how many people I'm just seeing are losing their kidneys and their livers as well. But the kidney is really a big issue. Now, there just aren't a lot of options for chronic pain. There's paracetamol, Tylenol, which doesn't do anything. There's these non-steroidals, which I mentioned, will just, again, if they don't give you an ulcer or a heart attack, will eat away at your kidneys over the years. It's fine to take them now and then. And then there's opiates, which nobody wants to be on opiates right now, except the people that are already stuck on them, because you get treated like a criminal. No one will prescribe them to you. And then the quality of life is worse. You're like sedated, itchy, constipated. It's much better quality of life to be on cannabis and on opiates. If you have the option, if you live in a place where it's legal, you can find a doctor, and if you could afford it, because unfortunately, our health insurance doesn't pay for medical cannabis, but it pays for opiates, benzodiazepines, any other more dangerous medication that you want to be on is paid for. So there are really 5 ways in which I think that cannabis can supplant the opiate crisis and the over-reliance we have on opiates. The first one is just what I mentioned, starting new chronic pain patients on cannabis instead of opiates. Again, as long as it's not like extremely severe pain, patients do really well. You start low, you go slow, have some CBD in, and get them so they're feeling a lot better. It's not even rocket science doing this. I think any general doctor or primary care doctor can do it. In England, when they legalized it, they said the primary care doctors, the general doctors, can't prescribe medical cannabis. I think that's exactly who needs to be prescribing medical cannabis. All doctors have to learn more about it, and we all have to be able to prescribe it. And then if it's a really complicated case, they can go to a specialist, just like we do with cardiology or any other issue. So number one, instead of starting opiates, start people on medical cannabis. I would say instead of starting people on daily non-steroidals, consider throwing in medical cannabis as well if you think your patients like their kidneys. But I think I've made that point enough. Hang on one sec. So this is just the impact of cannabis access laws and opiate prescribing. When cannabis gets legal, the opiate prescriptions go down. That's been showed pretty abundantly. Analyzing a data set of, well, this is just interesting. The morphine milligram equivalents went down by 11.8% and 4.2% respectively in states where they legalized it recreationally and then just medically. So there was a much bigger benefit when you just legalized it completely, as opposed to when you legalized it for medical uses and raised all these barriers to people using it. People tend to self-treat with cannabis. When they legalized it in Colorado, medically, the prescriptions for everything went down, which was really pretty astounding. And I think that people, instead of Viagra, they used cannabis. Instead of a muscle relaxant, they just treat themselves with cannabis rather than waiting a month to see a doctor. If they had pain, they'd use cannabis. So the prescriptions for a lot of things, instead of sleeping pills and waiting to see their doctor, they just treat themselves with cannabis. So the savings could be in the billions once we legalize. Way number two in which cannabis can supplant opiates. We have so many people, at least in the United States, that are on opiates for chronic pain, and you can offer to them to taper them off the opiates and taper them up on medical cannabis very slowly. And I've had a lot of success doing this. I've had patients thank me. Like one patient's back at school studying economics, and he said, I'd just be sitting around on opiates if you didn't, encourage me to make this transition. The one thing is it has to be voluntary. You can't force people off their opiates. We've had a lot of suicides in the United States because, everything's punitive and drug worry in the United States. So they're like, oh, there are opiate overdoses, so let's cut off the opiate prescriptions. So then people can't get their pain medication. They buy it on the street. It's contaminated with fentanyl and they overdose. So this has to be voluntary, not forced or mandated by the government. It has to be worked out with the doctor and the patient. You can't read this, but I just wanted to include it in the slides. It's just a really good slide showing that when they did exactly what I'm talking about, there was a 67% decrease in the morphine milligram equivalents per patient from 50 milligrams to 16 milligrams at the first follow-up. And then at the second follow-up, it went to 73%. I mean, that's a huge decrease in opiate dose. And most of the trouble you get in with opiates is dose related. You overdose and so forth. So the fact that we can get people off of opiates using medical cannabis is a huge victory for harm reduction. And this just makes the point that cannabis use was associated with a 64% lower opiate use in patients with chronic pain. Patients are doing this themselves, even without the few doctors that actually do it in the United States. They're doing it on their own. Cannabis use was associated with better quality of life in patients with chronic pain. I think anybody who's actually used cannabis, and in my past life, I smoked several acres on my own, understands that cannabis works for chronic pain and that it's a much better quality of life, especially if you experience with cannabis and with opiates. But again, this message isn't getting through yet to the doctors. So we're really working hard on that. And then the third way in which cannabis or cannabinoids can supplant opiates is they work really well together. Ziva Cooper does a lot of work on this in California. There's like a 1 + 1 = 3 phenomenon with opiates and cannabis. They co-work on the same receptor, and they've shown that you can reduce the dose of opiates and get the same by about 80% and get the same pain control. I mean, that's really pretty spectacular. The fourth way in which cannabis contributes to solving the opiate crisis is cannabis is spectacular for withdrawal symptoms. When you're withdrawing from opiates, and believe me, I've done this so many times, not recently, but you're withdrawing from opiates, you've got like diarrhea, stomach cramps, you're shaky, you're jittery, you can't sit still, you're anxious, you're depressed, you have a headache, you're nauseous, and cannabis alleviates not everything, but it alleviates quite a few of these all at once. What they give to patients is just clonidine or lofexidine, which are basically like beta blockers. They get rid of a little bit of the shakiness and the palpitations, but they don't do nearly as good a job as cannabis does. And it was I would say life-saving to me several times when I was withdrawing off opiates. You still feel horrible, but you don't feel like you want to die if you're using cannabis to withdraw off of opiates. I would say almost anybody in recovery from opiate addiction would agree with me. We test people in opiate treatment facilities and kick them out if they use cannabis in the US. And that's true for pain centers too. And that's so completely counterproductive and unethical. I mean, I just think these doctors have to get over it. People are using cannabis. You can't kick people out of a treatment program for using cannabis. It's just completely unethical. There is evidence. In most studies, cannabis use did not significantly predict treatment outcomes, opiate use, adherence, retention. This is in a buprenorphine program. So in methadone or buprenorphine, Suboxone in the US, you can treat them with medical cannabis, and there's good data that they don't do any worse. And in fact, there's some very good data that that it's extremely helpful. I mean, that's aside from the fact that everybody who's used it, who's withdrawn from opiates, will tell you that. There's actually some very good data as well. Cannabis alleviates self-reported opiate withdrawal symptoms. In a minority of patients, it makes them more anxious. But for most people, just like cannabis does in general, that's a side effect of cannabis. Some people can't take it because it makes them anxious. Same thing if they're withdrawing from opiates. Most people can take it because it makes them less anxious, especially at lower doses. So I found the use of cannabis like extremely helpful in getting over my opiate addiction, which is a very long story. Which I can't get into right now, but it is critical. The fifth way in which cannabis can help with the opiate crisis is more controversial. Now, I don't recommend this. I've heard of thousands of people, and probably know hundreds of people that have used cannabis to treat their opiate addiction. But the problem is there isn't good evidence for this, except anecdotal evidence, which can be very powerful, obviously. But we have two medications, methadone and buprenorphine, that are associated with a 50 to 80% decrease in opiate mortality, overdose, and deaths. So if you have a medication that has really good data that it decreases overdoses and death, and then it makes it very hard to advocate for using cannabis for that specific purpose. I believe, and the addiction doctors say that the cannabis industry is making irresponsible claims by implying this. And I don't think they're making irresponsible claims, but I just think it's too early to tell. I wouldn't be surprised if in 10 years from now there were methadone, buprenorphine, and cannabis to get people out of their opiate addiction. And it certainly seems like this is going to be the case. As I've just discussed, people who use cannabis use fewer opiates. They also use, many of the overdoses are polypharmacy, and they use fewer of the other drugs that contribute to the overdoses. They use fewer gabapentinoids, they use fewer benzodiazepines. So it's impossible to imagine that the cannabis is not going to be a solution for the opiate crisis. Moreover, I haven't seen any data on patients switching to cannabis and then overdosing about there being an increase. So as far as I know, this is a hypothetical risk from the addiction people, not an actual risk. However, I do agree that the stakes are too high. If I were to say, oh, you're addicted to opiates, try some medical cannabis, and they were overdose, I would feel really bad because that's not the evidence-based yet, whereas methadone and buprenorphine are. Cannabis doesn't contribute to overdoses because there's no cannabinoid receptors in the brainstem, in the part of your brain that controls breathing. So it doesn't cause respiratory depression. So that's why gabapentin, benzodiazepines, alcohol with the opiates can all contribute to overdose, but cannabis just can't contribute to the overdose. But maybe a way to compromise this is the level of evidence could be proportional to how risky it is, whatever you're treating. If someone has a migraine, I'm happy to use medical cannabis because the worst case that will happen is they'll get a migraine, they'll be a little bit annoyed at their doctor for giving them a medication that doesn't work, and we'll try one of the other 20 medications for migraines. Really no harm, no foul. But, if someone thinks it can cure leukemia, there needs to be pretty strong evidence, which there isn't yet, by the way, very strong evidence of that. Or if someone's using it to get over an opiate use disorder, they certainly need to, we need to have better evidence. So again, this is the one area where I'm not on board with recommending cannabis. I just don't think it is as evidenced a treatment as the other treatments. I did, if we had time, want to talk a little bit about doctors and cannabis, because I suspect that down under you guys have the same problem that we do. Patients know a lot more about cannabis than doctors. It's this weird situation where, again, they're not teaching or rarely teaching the endocannabinoid system in medical school. And now we're in a situation where 94% of Americans support legal access to medical cannabis. And among doctors, it's like 70 to 80%. And so because the medical societies and the government have been against it, we've been legalizing it by state referendum after state referendum. And then the medical societies are like, oh, you silly patients don't know what you're doing. You shouldn't legalize it by state referendum. And the patients are like, we want medical cannabis. It helps us. Why are you standing in the way of something you know nothing about? So we definitely have to not only improve communication between doctors and patients, but we sort of have to get everybody on the same page, which is basically the book that I just wrote. Hang on one sec. Hey guys, can you keep it quiet? I'm giving a speech. Sorry, I have teenagers in the house that I've only told about 50 times that I'm giving a speech, and now they're right in the next room screaming at each other. So anyways, the doctors complain that the patients don't get information from them, but then when the patients try to, they end up generally empty-handed. And then the doctors complain that the patients are getting information from other people that aren't the doctors. Like, who's the patient? Who are the patients supposed to get information from? So it would really, really help to educate doctors about cannabis, not the nonsense that they received in medical school, but, which is sort of watered down drug war nonsense, but really good education so they understood the endocannabinoid system, the basics of prescribing, and they could work with patients. And again, then if it gets more complicated, they could send someone to a medical cannabis specialist. I don't think you need to be a medical cannabis specialist to take care of someone with medical cannabis. I take care of people with opiate addiction. A lot of primary general doctors do with Suboxone. We're not addiction specialists. And it works out really well. The barriers are already mentioned, the lack of education, but there's also like cultural bias because of the war on drugs. I mean, our government spent 80 years convincing people that cannabis was like the devil's lettuce. And now there's been a huge change in public opinion. And, doctors are just conservative people. It takes them a while to go along. And it does require a paradigm shift. How to certify, how to manage. It's a new skill to learn. And doctors are already like very, very overloaded. Finally, there's federal illegality. It's hard for, I could lose my medical license each time I recommend cannabis because it's illegal on the federal level if it's legal on the state level. So doctors are afraid of that. They really shouldn't be in states that have legalized it. But once we get federal legalization, this will be much less of an issue. And then finally, doctors sort of hide behind it hasn't been proven by a randomized controlled trial, so it might not be true, even though any doctor in the audience knows that we do tons of things that haven't been proven by randomized controlled trials. And then furthermore, like all the harms of cannabis that they so strongly purport have not been done by randomized controlled trials. You can't do a randomized controlled trial on a 15-year-old and say, here's a lot of cannabis, and then take another one and say, here's no cannabis, and then, oops, your kid's brain dead. Sorry, cannabis does affect the teenage brain. Like, it's unethical to do that kind of experiment. So I just don't get why there's such a double standard. And then the final point is that who pays for the medical cannabis? Like, at least in Canada, they subsidize it, but in the US, a lot of people can't afford it, especially if they're on fixed incomes. The US is where, like, if you're rich, you get great healthcare, and if you're poor, you sort of rot, go bankrupt, and then die. We have the most unjust medical system you could possibly imagine. And it's very broken in terms of something like medical cannabis because you have to pay for it yourself. And obviously, a lot of people aren't in a position to do that. And medical cannabis can't be just for the wealthy. It absolutely can't be. That just does not work at all, I'm sure, for any of us. So a couple things that I mentioned before that I hope for, because I'm running out of time, is that I really do want cannabis to not necessarily be viewed as like a last resort on these treatment algorithms. I think it needs to move up. And, if you could make the argument that cannabis is more dangerous than a benzodiazepine or zolpidem or an antihistamine or a tricyclic for sleep, go for it. But I think that's a very hard argument to make. I think cannabinoids should be way higher up on the list, for example, for insomnia, not just for chronic pain. As I mentioned, it's critical that we have better communication between doctors and patients. This is really, really dangerous. And I'm sure it's the case in Australia as well, that people are afraid to tell their doctors. The doctors are kind of old and stuffy and like, I don't believe in that. And then, it creates two care systems, one with medical cannabis and one with the regular medical care that don't communicate with each other. And it's very, very dangerous. I think medical cannabis is going to be huge in end-of-life care. When my dad passed away, we were able to get him from this world to the next world with 3 doses of morphine because medical cannabis was so effective. And he was much more with it than he would have been if you were just groggy on opiates. I mean, we had a Zoom birthday for him the night before he died, which he participated in. Of course, we didn't know that was the night before he was going to die, but it was just a beautiful thing. And it never would have happened if he was zonked out on opiates. So I think it's going to be huge in end of life care. I feel strongly that it needs to be legalized, not just for medical use, but there's such a fine line between medical and recreational use. Most of the use is actually somewhere on the continuum in between. I mean, obviously, if it's a dying cancer patient, that's medical use. And if it's before going to a concert, like a Grinspoon concert in Australia or a Grateful Dead concert or something, it's recreational. But most uses overlap between the two. This has been studied. People who get their cannabis at recreational dispensaries use it medically for headaches and for insomnia and for chronic pain. And most people who use cannabis medically also can use it recreationally as well, probably because they realize that it's more interesting and less toxic than alcohol. So I think it's really important that it get legalized so people can use it for like spiritual purposes, interpersonal purposes. Some people find it really helps them connect with other people. Creativity is just, astounding how much the creativity can be fostered by cannabis. People say it helps their sex lives. There's no reason for it to be illegal. Absolutely. I mean, it's great that we're legalizing it medically, but it absolutely needs to be across the board legal. There's no way to argue that keeping it illegal is safer or better for people than keep making it legal and regulating it, taxing it, and providing people with a safe supply. Finally, I want to end with a quote that I find very inspiring. This is the astronomer Carl Sagan. I joke, me teaching him how to read. This is him teaching me how to read. He was a fixture of my childhood when I was growing up. And he wrote a chapter from my dad's 1971 book, which is a spectacular chapter about his personal use and the way in which cannabis informs and deepens his scientific process and his creative process. Really just an amazing, it's easy to find online. He wrote it as Mr. X. And then when he died, my dad told everybody, hey, Mr. X in my book was Carl Sagan. And Carl Sagan says, quote, "The illegality of cannabis is outrageous, an impediment to full utilization of a drug, which helps produce the serenity and insight, sensitivity and fellowship so desperately needed in this increasingly mad and dangerous world." Amen to that. I'm on Twitter if anybody wants to find me, or you can find me on my website. And it's been a pleasure. That's it. My time is up.
Hello, Peter. Thank you so much. I'm the MC today. My name's Helen, and it's been a really wonderful presentation. And I know certainly the organiser of this conference, Lucy, was much inspired by your father's book. And thank you for such an enlightening presentation. It's humbling to hear your journey and where we've been and where we're going. So I wanted to know if it was okay if we could maybe have a little bit extemporaneous, but a quick Q&A, if you don't mind taking a few questions.
Absolutely. I'll answer questions all night, or all day, I guess, for you guys.
Thank you so much. Thank you. Anyone got a question for Peter? Yep, thought there would be. Oh, are the kids... we want to know, are the kids okay? Have they quietened down?
Well, first of all, they're not kids. They're like 21 and 20. So they
should have known better then, seriously.
I only told them about 50 times each that I'm giving a presentation. But yes, they have stopped strangling each other in the next room, and they're either like braining each other somewhere else or moved on to a quieter activity. So thank you for asking.
Terrific. All right, we've got a couple of questions. Here's the first one.
Hi, Peter. Andrew Proudfoot, avid follower on Twitter. And thanks again for all the things you do for public health around the world in this space. I just had a question. Are you using any of the Viron strains in your clinical practice? And could you give the audience a little bit of an explanation on the Virons?
What I use in my clinical practice, the Virons are just different cannabinoids with a different chemical attachment to them, like CBDV instead of CBD. THCV is the variant of THC, and THCV is a very interesting, variance is a chemical name like hydroxy or whatever. And like THCV, for example, is very interesting potential for weight loss, not just in animal studies, but in human studies too. It controls blood sugar, it controls appetite, and it controls insulin sensitivity. So I think it's going to be huge. We have the biggest diabetes and obesity epidemic you can imagine. I think you guys do too. I think it's happening a lot of the places. And we have this cannabinoid, which is non-psychoactive or minimally psychoactive, and helps people with their appetite and helps them with their glucose control without causing low sugar. It's going to be huge. So I think the varins are a huge avenue that we're going to be pursuing clinically. In my current practice, I tend to just treat people with what's available to them to get. A varin, they would have to send away for, and it's just a lot more trial and error if they go into the dispensary. We have these dispensaries all over the place where they can get all kinds of things. So I usually stick to THC, CBD, CBDA. I'll use an acidic form of CBD, and I recommend the varins, but the problem is the quality control isn't very good in the United States. These are supplements. They're not medication. So anybody can produce anything and say, hey, this is THCV or this is CBDA, and there's very poor quality control. So I believe we're going to be using the varins a lot more in the future, but right now there's not that much access to them. And because that means they have to get them not from a dispensary where everything is regulated, controlled, monitored, and tested, but from some fly-by-night company over the internet. I don't feel particularly comfortable having my patients do that. So I would say yes, but not quite yet.
Anyone else? Any more questions? Yeah, awesome.
Yeah, what do you think of the non-heated oils, like, like you just mentioned THCA and CBDA, because there are some companies here that are extracting through oils, and I'm just curious about your thoughts about that.
Well, if I can make a general comment, what happened with CBD is CBD genuinely helps people, but the marketing claims soared so far above the actual scientific data. The scientific data is getting there, and we're getting more every day. But the marketing claims are out of control. We have CBD bras, we have CBD workout clothing, we have CBD pillows. Like 1 in 3 Americans have tried CBD, and 1 in 7 Americans are on a CBD product. So and the regulation is really poor because, again, if you buy CBD, you don't have any idea what you're getting. So I think that, again, there's a lot of potential, but I would just make sure that there's good research. And it can't just be research, just like it can't be research done by the US government, which is going to find that nothing works and it all kills you. It can't be done by the company per se, or ideally it shouldn't be, because they tend to have a very rosy spin on things. So I think we need more independent research. And for me to use that more in my practice, I would need more availability, more quality control, and more research. So again, I'm sorry if I'm sounding like a broken record, but we're on a very exciting time where all these minor cannabinoids and all these THC analogs are coming out. And it's, in one level, it's so exciting. I mean, in the US, we have there's not just Delta 9 THC, there's Delta 8 THC, Delta 10 THC, THC 0, which is a weird THC where you smoke it and nothing happens for 25 minutes because it's a prodrug and it takes a while to metabolize and actually become active THC in your body. I, of course, forgot this and I read it the night before, and then I went to a play and I kept puffing on this thing and I'm like, this doesn't work at all. And then 25 minutes later, boom, it's like it hit me all at once. So, but yes, there's so many analogs of THC and of CBD and so many of these new molecules and so many different forms for topicals and so many different claims are being made. And I would just say we have to pay a lot of attention to the claims and not get ahead of ourselves and really make sure there's some evidence behind it, because, anecdotal evidence will only take you so far. I think real world evidence is great, but I think we're sort of in a transitional period. We're fighting so much over legalization. We could be spending a lot more of this effort improving the products and guaranteeing their quality and doing the research. But so I think we're getting there, but I'm not heavily reliant in my clinic because, again, I rely mostly on what's available, and it works really well.
Peter, is there enough industry support in terms of funding the real-world data in the US?
Well, it's a good question. I would say yes. The real challenge is getting physicians and medical societies and like the FDA, the Food and Drug Administration, which regulates drugs and medicines, to accept the real world data. So the industry is doing a really good job with the real world data, and so are a lot of the state registries. You know, you have to certify with the state, state by state, and then so the state of Massachusetts has all this great information that they could use on who's using what and for what and so forth. There's a ton of information. I think I think they are doing a really good job. The hard part is getting the sort of, you know, overcoming the like old fart syndrome medical establishment to like change their paradigm and just say this isn't something bad, it's something useful. I mean, the irony is it makes my life so much easier as a general doctor. I have this versatile tool for pain, for insomnia, for PTSD, for anxiety, for fibromyalgia, and it makes my life easier than it does to the other doctors because they don't have it. So I really do think that we have enough evidence. It's a question of, you know, we could always use more, and we need evidence for each new thing that comes out. For example, THC-8 is analog of THC-9, and it's touted as a THC that doesn't make you anxious. So it has everything good medically about THC, but none of the anxiety or paranoia. But the fact is we don't really know if it's safe because it's just 1 out of 500 molecules in cannabis. And now they take it, you know, and you take just delta 8 THC, it's probably safe, but we don't know if it's safe. So I just think they are doing a good job. But first of all, we're catching up for lost time because all the focus has been on harm. And again, it's a question of credibility, getting the right people who hold the levers of power, the insurance companies, so they'll pay for it. They're not going to, at this point, accept patient-reported outcomes. They hide behind the lack of randomized controlled trials. And I guess what I'm saying is that part of it is scientific and part of it is political. And, you know, as a doctor, I wish that it were all scientific. But as someone who's been involved in the legalization movement, like since before birth, I understand that there's a really political component to this. So we have to sort of balance both at the same time. So yes, I made a short answer long, but the industry is doing a good job with real world data, but we also have to sort of encourage / force the authorities to accept that as legitimate data, like they do on harms of cannabis for benefits of cannabis. So we don't have things like the International Association for the Society of Pain saying there's no evidence that medical cannabis works, which was a slide that I started with. So yes, we have good data, but it's being not listened to by a lot of people.
Well, that's not dissimilar to the situation here in Australia as well. So we can absolutely relate to that. I don't see any more questions, so we'll wrap it up there. But I just want to say thank you so much. It's just been really enlightening, and how extraordinary for you to be continuing your father's amazing legacy. And actually right next door, we have a group of doctors this morning being educated. So hopefully we'll see this paradigm shift slowly but surely. And thank you for your efforts in all of this as well. Extraordinary. Thank you for sharing your story.
Well, enjoy the rest of the conference, and next year I'll try to be there in person.
Oh, we hope so. That'd be terrific. Thank you.
Thanks, you guys.
Thank you.